Welcome to another CME podcast episode from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Stephen Stahl about best practices for switching antipsychotic medications. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Stahl discuss the current research and guidelines on switching antipsychotic medications.
Hello and welcome to another NEI CME podcast, this one entitled The Art of Switching Antipsychotics to Better Treat Patients with Schizophrenia. And it is, as always, my distinct pleasure to have with me today Dr. Stephen Stahl, the one and only. Steve, how you doing?
Great, Andy. Great to be here with you.
Yeah, I think this one, Steve, is really very clinically practical. You know, if you look at the CATIE study, for instance, the famous CATIE study, we see that switching happens quite a bit with antipsychotics, and yet there really aren't a lot of established guidelines to tell us how to switch. So I think this is going to be really helpful for our audience to sort of think through some of the principles. I mean, rather than us just giving them a cookbook of how to do it, Steve, probably we should talk about some of the underlying principles to keep in mind.
Really good point, because there are really no studies that guide us. Studies are done with patients in a way in which, it doesn't seem to matter how you switch. So it does matter, anybody who's actually treating patients. And that's based on applying these principles that you just mentioned, we can talk about them, to the real world.
Yeah, absolutely. It's interesting you mentioned that. I've been an investigator on several of these industry-sponsored switching studies. And you're right, I just don't know that they're done in a way that's really designed to help answer the question, the best way to do it.
The newer drugs didn't even get into switch studies because of that very thing. Right. It didn't matter. So, and then people say, how do you switch? And they shrug their shoulders because there's no guidelines. So here we're going to give you the guidelines.
Absolutely.
Principles.
Well, Steve, here's how I think about it, and tell me what you think. Doesn't it really come down to pharmacokinetics versus pharmacodynamics of the drugs that you're talking about?
Good point. For example, some drugs have short half-lives, and some drugs have extremely long half-lives. And the ones with short half-lives tend to get tapered, and the ones with long half-lives taper themselves. You just have to cold turkey them when you stop those.
Yeah, that's how I think about it, too.
And pharmacodynamics would be mostly the off-target stuff. That's the pharmacology of stuff that's not the D2, and then whether the D2 is extremely potent compared to other ones.
Yeah, exactly. So let's dive into some of these receptors that we're talking about. Not D2 is obvious, but when you're talking off-target, what other receptors are we talking about? And these are probably receptors that are predominantly responsible for side effects.
Right. And so basically, you're talking mostly about cholinergic muscarinic antagonism, which is the big bugger. But associated with that very frequently, almost always, is antihistamine. So H1 antagonism. And then you've got a number of other things that kind of, we said, I think in my book, there's the penes and the dones. Well, the penes tend to be those olanzapine, clozapine, etc. And they tend to have anticholinergic and antihistaminergic. But some of them, like, say, lorazepam and some of the newer drugs, don't have really any.
That's right.
It's a difference whether you got it or you ain't got it.
Right. Well, the penes seem to have short half-lives and these off-target receptors. So it sounds to me like the penes, we need to be especially careful coming off of them, taper them extremely slowly.
Exactly. Here's the problem. When you block a receptor, it gets mad. And it says, you block on my receptor, I'm going to block you more. And it ends up, adjusting. So if you all of a sudden take away the blockade, there's this really sensitive situation which you left behind. It nude. All those receptors you've been blocking are nude of drug. And then they get mad. And it's really mostly seen in a bad way in very young or very old, when they're very vulnerable. If you take, if any of you listening here or take care of kids, if you take an anticholinergic agent and cold turkey it, they will get more GI symptoms in withdrawal and sweating as well, and also the elderly, and maybe the people in the middle of the age group. So if you cold turkey people after you've been blocking the receptors for a long time, you don't have the time for them to adjust. And that's why you keep a little bit of drug there so that as the receptors adjust, you block them less and less because you don't need to because they're adjusting, and then you wash them out, and then it's all gone.
Yeah, that's a really good point about the different ages. Especially the elderly are so sensitive to delirium with anticholinergic drugs, either too much anticholinergic or pulling it off too fast, as you said.
Exactly. Yeah, that's a big point.
Other receptors I think about, Steve, are especially alpha norepinephrine receptors, the alpha adrenergic receptors. Those too, if you come too fast off of those.
They cut both ways, Andy, because in the old days, we used to think that they were just sedating and cause orthostasis, particularly alpha-1 antagonists, even going back to tricyclic antidepressants, which have some of these very same properties we're talking about here. But then it's beginning to look like alpha-1 antagonism could be helpful for nightmares and PTSD, and also seems to have some activity maybe in agitation, because some of these drugs are used for agitation, not only in schizophrenia, but some of them are going forward in Alzheimer's disease, which has that. So again, the alpha-1 might cut both ways, be good and also possibly bad. So again, it's a matter of adjusting. Certainly you don't want to have a rebound by stopping it too quickly. And you also don't want to start too quickly because that causes, problems as well.
Yeah, doesn't alpha-1, especially alpha-1B blockade, might also help with akathisia? I understand.
Might, exactly, because the alpha-1 receptors tend to be localized in the same place the serotonin receptors are. And so if you block serotonin 2A while you're blocking alpha-1, you end up getting a twofer.
Yeah.
The drugs that actually have alpha-1 antagonism, particularly with good 5-HT2A antagonists, tend to have less akathisia and less EPS.
Well, the one that comes to mind, of course, is one hardly anybody uses, iloperidone. It has very high affinity for alpha-1, and that's why we give it twice a day and titrate it. But that one didn't have any akathisia versus placebo clinical trials. And then a lot of people may not realize mirtazapine is an effective treatment for akathisia, and that has 5-HT2A, but also some alpha, I believe.
Yeah, and I think it's the 5-HT2A antagonists are basically a forgotten treatments for akathisia. First of all, many people confuse akathisia with an EPS and give an anticholinergic to no avail. That won't work for akathisia, although it will work for EPS. But 5-HT2A antagonism, including with even drugs like trazodone sometimes, with mirtazapine, as well as the classical beta blockers and benzos. So there's that one thing. And so because some drugs have a lot of 5-HT2A antagonism, they tend to have less EPS in general, because that counters the EPS and the akathisia.
That certainly makes sense. Now, let's talk a little bit about cholinergic and histaminergic rebound, just so that people can get a sense of what is it they might see if they go too fast. So what do those two look like?
Well, in some ways, it's the opposite of blocking. So if you get dry mouth, blurred vision, constipation, you might get, salivation instead of, and pupil changing and sweating and diaphoresis and, diarrhea.
Diarrhea, the other dia.
And vomiting instead. In fact, funny enough, you do see some of these with the procholinergic drugs that are being tested in schizophrenia right now that are M1, M4, M5, and so forth agonists. So what you're doing is you're getting too much acetylcholine instead of too little for a while, and then it adjusts down.
I think that's really helpful, though, what you just said. Think of it as the opposite of what you get with antihistamine and anticholinergics. So if you come off the histamine too fast, you can get agitation and some other things that are pretty nasty.
It's on there because
that's right.
It's the opposite.
That's right. Exactly. And people really don't like it. They'll describe almost a flu-like syndrome. It's really uncomfortable. So,
well, we're here, one of the things I want to mention, it is possible, more so than ever, that there is a such thing as dopaminergic rebound. Classically, people said, well, we don't get too far off target here because we're talking about switching, but the D2 antagonists, when you block chronically, might cause tardive dyskinesia in the motor system, but they don't do that in the psychosis system, or do they? So there's some question if you withdraw a drug too fast, you might even get psychosis rebound because there is first of all, you're not blocking the receptors, but there may be an extra problem here, which is that if you sensitize your basically your psychosis receptors, just like you sensitize any other receptor you block, we're talking about the cholinergic and histaminergic, why wouldn't the D2 be sensitized? They are in the motor system. So there's increasing risk that people are worried about with chronic treatment, that if people withdraw their antipsychotics inartfully or just stop them, they can get rebound psychosis as well. So we don't want to do that during the switch scenario, which is a very short period of discontinuation or cross titration. But you have to be careful. If all of these things you've been blocking for a living for a while, if you stop blocking them, it takes time to readjust, including maybe D2 receptors as well. M1, 2, 3, 4, or 5. There's 5 cholinergic receptors, and at least the H1N receptor.
Yeah, so not only can you get cholinergic and histaminergic rebound psychosis, you can get all kinds of other side effects. You can have them go into withdrawal. So, I mean, it's really risky. Now,
the other thing that happens is that you usually get some sedation with these cholinergic blockades and histaminergic blockade, which is not the world's greatest, but it certainly does work in some people with psychosis. So if you lose your sedation and you go to a non-sedating agent, you may need to be aware of the fact that for a while, until the patient has adequate D2 blockade, that they could actually have worsening of their psychosis during the cross titration.
Right. Well, I always found your song to be incredibly helpful, Steve. The Peens, the Dones, 2 Pips, and a Rip.
It's made it to the top 40,
It was. Casey to announce.
You should play it for him.
That is a great idea. Maybe we'll get that added to this podcast. But I do find that extremely helpful. The Peens, as we said earlier, in general, tend to have shorter half-lives and tend to have a lot of the antihistamine, anticholinergic. The Dones tend to be higher affinity for D2 receptors, kind of intermediate half-lives. Some of them have the alpha blockade that we talked about. And then, of course, the Pips and the Rips, the ABC drugs, aripiprazole, brexpiprazole, cariprazine, they all have super long half-lives, 96-hour half-lives. And they don't have much in the way of anticholinergic or antihistamine. So I think that you can sort of think about when you're switching, what are you switching from and what are you switching to? And switching from the 3 buckets kind of gives me a sense.
Putting them into those 3 buckets.
Yeah.
And where do you put lumateperone?
Well, I was just going to mention, lumateperone doesn't fit into those buckets. It's a Rhone instead of a Peener. And it's unusual, isn't it, Steve? It only has 1 approved dose.
Right. And so it's harder to titrate, but then you can use other ways to do that, which is when you need to institute it, you institute it at the full dose. Sometimes with the other drugs, you can institute the new drug at an ineffective dose and then raise it. So that's just a little bit of a difference in terms of that. But you're right. Depends on which one you're coming from. So that's the principle is that always think of the drug you're stopping as well as the drug you're starting, is in terms of how to actually, switch.
Well, would it be too simplistic to say that if you're coming off of one of the ABC D2 partial agonists, that you can basically stop them? They've got 96 hours half-lives. They're going to auto-taper. So gradually.
Exactly. Well, if you don't do that, it takes forever. You're never going to get a switch. So,
especially because they have such high, people don't realize that D2 partial agonists have such high affinity that the other drug's not going to touch the receptor for a while anyway.
So you want to get off that one for some reason, go to the next one. The worst thing you can do is keep this very potent D2 antagonist around even longer than its natural washout, which is, of course, 5 half-lives. So if you've got, a 2-day or a 4-day, or in some case, a 2-week half-life with active metabolites, my goodness, it takes a long time.
That's right. So would it be too simplistic then to say, okay, so that bucket, the ABCs, we stop. The Peens, well, the Dones would be intermediate. So the Dones, taper over 1 to 2 weeks. The Peens are the ones really at least 4 weeks, wouldn't you say?
Generally speaking, yes. Now, like everything in medicine, the answer is it depends. So, I mean, if you have a very bad side effect, you want to get rid of the drug faster than that. If you have a very bad problem with efficacy, you may want to blast the patient with the second drug fast. But if you're not in those circumstances, which are probably inpatient circumstances, an outpatient, most tapers are done as an outpatient. Most tapers are done really for side effects, probably more than for efficacy. And then you need to take, most people are seen in clinics, once a month? And so you can do something for a month and then change it, but leave the intervention alone for at least a few weeks.
Yeah, that certainly makes sense. So what we're basically recommending, it sounds like, is the cross taper strategy, where you're coming down on the first one, coming up on the second one, unless it's lumateperone, where you just start full dose.
And so, I mean, and also to your point, it's a cross taper even if you cold turkey the ABC drugs. So that is cross tapering because the drug is sliding down on its own. You don't have to, lower the dose gradually. You got to get, and it's a no problem. There's no noted rebound or anything with the rate at which it auto tapers. So just stop it fast. And of course, not only the penes in general, but clozapine in particular, there's something funny about clozapine stoppage among that pene. Don't do it too fast, or you will get actually more likely recurrence of psychosis, let alone the problem with it's highly anticholinergic and antihistaminergic.
Yeah, so clozapine in particular, you've got to be careful coming off of.
About 4 weeks for sure. You can sometimes get away with 2 or 3 weeks on one of the other penes, but it's individualized. So the general principles are: be careful of penes rebounds and go a little more slowly. And the other thing, though, we didn't even talk about this. How about if you're going from a pene to a pene or a dome to a dome? You can do that because they're more like each other. But when you're going from a pene to a dome, you're losing all your anticholinergic blockade. And so that's the one we slow it down. If you're going from a dome to a pene, the dome probably come down fairly quickly, and the pene, though, can't go up so fast generally because you've got tolerability issues. And so it really kind of depends on which direction you're going, and just keep in mind there's about 3 or 4 principles that you need to know. That's easy enough. Most of us can count 3 on a good day, at least I can. And so melt this whole switch stuff down into about 3 principles, then you just apply it to which specific drugs you're working with.
Well, that's why I find your song with those buckets so helpful. and then thinking about it in terms of pharmacokinetics, the metabolism, the half-life versus pharmacodynamics, which is what receptors we're talking about. And it's not only which receptor, it's how tightly you bind. It's the affinity you have to the receptor, right?
Yeah, there's some evidence, like, for example, that drugs that have to be given in very high doses, say like quetiapine or even clozapine, don't bind as avidly to the receptor. So if you have another drug that does, then the competition is in favor of the one that binds tighter.
So how about, we alluded to D2 a little bit. Let's just focus on that for a minute. What would we recommend switching from a medicine with a high D2 affinity to one with a lower D2 affinity?
Well, what you want to keep in mind is if you're switching for efficacy, you do not want to lose any of your net D2 antagonism, right? So I had a patient, he's not doing well. I don't like this. Well, let's say one of these ABC drugs or whatever. And so therefore I want to give more. The ABC drugs taper themselves, so I got to get rid of it fast, which means I cold turkey it, but I realize it's going to win with the receptor for a couple of half-lives. And the reality is that if you're not careful, you will lose D2 antagonism in that switch time instead of gain it, which is the exact opposite of what you want. You're switching because you want more. So in that case, you probably have to pile on the next drug as fast as you can, realizing that it's not going to win at the receptor until it vacates just naturally through the dissipation. And so cold turkey the first drug, and you depend on the urgency. If it's for efficacy, you go fast on the second drug. If it's for tolerability, you don't go fast on the second drug. You let the first one float down, and you kind of bring a subtherapeutic dose in and bring it on up. Now, in the case of a drug that has a single dose, then what you end up doing is perhaps waiting a little bit longer before you institute that drug. In this case, it means something like lumateperone. And so, whereas if it's something like if you're going from an ABC drug to a pene, then you can use a subtherapeutic dose of a pene to start. Maybe even the first day you stop the ABC drug. But the ABC drug's going to be around half of it's going to be around for, days. So you aren't going to really do much switching. So in some ways, you have to set your expectation on when you're going to arrive at the destination. And when you're stopping on an ABC drug, it's going to take longer for you to get on that new drug and the new drug to be driving. If you stop a short half-life drug, say like a Doan, you get there faster.
Well, let's flip the tables. What happens if you're switching from a medicine with low D2 affinity to one with high D2 affinity? What do we have to think about there?
As soon as you put the high D2 affinity drug in, the low D2 affinity drug has been washed out. You might still have, you still even be taking it every day, but let's say aripiprazole is a classic one. And if you don't believe me, I dare you to do the following. Take somebody who's got a high prolactin, prolactin or not, and then give them a very tiny dose of aripiprazole. Mm-hmm. Look what happens to prolactin. And so it's going to win at that receptor, which tends to be more sensitive. And so aripiprazole is actually reversing the action of the first drug, as proven by the fact that prolactin will be going down. So if that's happening in the psychosis center, then what it's saying is that aripiprazole is going to come in and kick off any other drug, except another ABC drug, from that receptor. And so you don't want to be timid about starting the aripiprazole, right? You want to get a decent dose up there because you're going to end up having a case where the patient's on a lower affinity D2 drug, olanzapine or something like that. Most of them are. You start aripiprazole, all of a sudden you just have quickly washed all the olanzapine off the receptor. And what do you think that's going to do to a patient who's psychotic? Not good. So you want to make sure you're kicking the receptor pretty hard with the new aripiprazole. And in this case, actually, people listening know this. You're not really generally switching to an ABC drug because of lack of efficacy. You're switching because of lack of tolerability, maybe to try to get better metabolics. Mm-hmm. So usually you're not as worried because of psychosis. It's not the reason for the switch. And so you're quite careful about the D2 part of it. But whenever you give an ABC drug, it wins.
Right. Certainly at the D2 receptor, but then of course there's always the other receptors we were talking about. So you do have to be a little careful there with how fast you come off of the other drug, the lower affinity drug.
Right.
From that point of view. So when we're talking about lumateperone, the newer one, which kind of doesn't fit some of these rules we're talking about, it sounds like starting lumateperone is pretty straightforward. You're always starting it the same way. What happens now if we want to come off lumateperone? I'm just thinking lumateperone doesn't have a lot of off-target receptors. It's a pretty straightforward medicine, isn't it?
Yeah, it tapers itself as well. You should be able to stop it pretty fast if you want to get off of it and go on to the next one. And of course, lumateperone's easy to start if you're on nothing, but almost never that's going to happen, right? Everybody's listening and saying, well, I'm going to switch because it's a newer drug and generally it's not a first-line drug because of cost. But when you want to go to it and you're already on something else, then that's when the question occurs. And you have generally what I would do is stop the first drug at the rate that is proper for that drug. So like we already said, a little bit slower if it's a peen, a little bit faster if it's a Doan. And wait a little bit until you've had maybe one half-life at least washout, which is a day. Mm-hmm. Okay. And then you start the lumateperone, because lumateperone's going to be a lot of D2 antagonism at its full dose, and to what's still a lot of antagonism of the first drug, and you might have undesirable side effects. So you want to basically try to keep if you're happy with the antipsychotic effects and you're not happy with the side effects, you want to keep the D2 antagonism about the same. Now, furthermore, maybe people are going to give a drug like lumateperone not for its D2 antagonism, but for its other more mysterious effects, like they all are in bipolar depression or something like that. Mm-hmm. And then what's happening, you still don't want to have problems with the residual of the first drug. So I would tend to watch it out a little bit.
That makes sense.
And then start the lumateperone, at least a day, maybe two.
Yeah, I'm glad you mentioned that, Steve, about bipolar, because we're using these drugs, of course, not just for psychosis and schizophrenia. We're using them now for mood disorders. And those patients tend to be even more sensitive.
Well, realistically, we're using the themes and the don'ts more for psychosis, and we're using the ABC drugs more for unipolar or bipolar depression. That's just the reality. And so the switches in the psychosis world will often be among themes and don'ts. And the switches among the other mood drugs would be between the ABC drugs and the lumateperone. And of course, you throw the lorazepam in there too.
And lorazepam, yeah, of course, the Zidone. Yeah, so that's interesting. But again, and we tend to use lower doses for certainly the antidepressant than we do for the antimanic or antipsychotic. So
yeah, exactly. And
so
what you're going to be doing is, in those cases, you'll have lower kinds of doses of your ABC drug or your, say, lorazepam, which is approved in the depression sphere, particularly bipolar, going to a full dose of, let's say in this case, lumateperone, or to a lower dose of one of the other ABC drugs, low dose to low dose. And in that case, you probably can switch fairly quickly. Again, if it's for tolerability, it's best not to ram those things through. If it's for efficacy, I can understand. But you know what? You can get acute efficacy by blocking D2 receptors really fast. You don't get acute efficacy when you treat bipolar depression. You know, it's going to take a while anyway. So allowing the switch to occur mercifully and tactfully and gently will allow the patients to stay on it long enough. If you basically ram it into reverse and create all sorts of side effects, through this, I'm not going to take this drug, and then you've aborted and lost the chance for a good drug to be.
Yeah.
You know, another thing is that, Andy, you know, when you switch it from A to B and something goes wrong, almost always you blame B.
Yeah, that's true.
You don't blame stopping of A. But in many cases, it's really the inartful stopping of A which is causing your trouble. Yes. And so you lose a chance to use B, and that could be a very important drug.
Well, yeah, I vividly remember when aripiprazole came out and we started switching everybody off of particularly olanzapine. We would just stop the olanzapine and start aripiprazole, and then we said, oh, aripiprazole is making them agitated. And you're right, it was the cholinergic or histaminergic rebound.
Right.
So you're 100%.
It's that hard, but there are some important principles. And, you know, not one size fits all. There's about, 3 sizes on the racks.
Right. Now, there is another receptor we didn't talk a whole lot about, but what do clinicians need to know if they're thinking about the 5-HT2A receptor when switching? How does that play into this?
Well, it doesn't seem to have a lot of rebound if you stop it precipitously, but it certainly is important if you go from a drug that has high 5-HT2A to the drug that has lower 5-HT2A. It means you're going to have more EPS or akathisia possibilities.
Yeah.
So
and that's interesting because that's interesting because the ABCs tend to have a little less 5-HT2A.
Like cariprazine has almost none.
Yeah, which is interesting. So they are associated with akathisia, certainly.
But there's a savior in here, and that is as goes 5-HT2A antagonism, so goes 5-HT1A partial agonism. So the best drugs have the least EPS would be those that have both. And who are those? Well, ever hear of quetiapine? Yeah, very strong with both. Clozapine. So some of the reasons that there's very low akathisia is because they have both 5-HT2A and 5-HT1A. Now, if you go to a drug that just has 5-HT1A, like cariprazine, then, of course, you may have a little more akathisia. Or you go to a drug like aripiprazole or brexpiprazole, which have lower 5-HT2A compared to some of the others, might have a little more akathisia. That's why those drugs do. So the lack of akathisia, or the lack of, 5-HT2A means be careful, because akathisia is probably the easiest way to treat it is to lower the dose if you can. If you can't do it because of efficacy reasons, then you have to treat it or switch. But 5-HT2A is a big factor in whether you have akathisia or not.
Yeah, I always say akathisia is dose titration and blood level related. You know, faster you go, higher you go, more likely to get akathisia. So you're right, backing off is the way to go. And then the best way to treat akathisia is to prevent akathisia, I would argue. But having personally experienced it.
While I'm thinking about it, you know how you can tell the difference between akathisia and agitation? Because they look often the same.
Very
And
similar.
young doctors particularly, or young prescribers, will often not know. And I think the answer is raise the dose. So with eating, you just made the patient worse.
It's
With the
worse.
yeah. And then if you lose agitation, you make the patient better. So generally speaking, it can be difficult to tell the difference between those two things, but you can use drugs to try to clarify.
Well, you've just got me thinking about something else. This newer drug we've been talking about, lumateperone, has really high, probably some of the highest 5-HT2A. And you completely saturate those receptors at therapeutic doses.
It's really amazing. In fact, if you use a lower dose, you actually pretty much have a 5-HT2A antagonist. At the dose that is approved, though, it's of course blocking some of these other receptors. And if you raise the dose on the 5-HT2 side, you can't block more than 100% of your receptors, so you
That's
don't.
right.
But you probably are right. At current doses, you got every one of those darn 5-HT2A receptors blocked. And so that should be useful for a number of things. That people have linked that to better sleep. They've linked that to better EPS we just talked about, but also possibly negative symptoms improvements. So some of those are not well documented yet, but hypothetical and different levels of evidence for them.
Well, we know pimavanserin is being looked at for that, which is also 5-HT2A antagonist. Adding pimavanserin to antipsychotics.
A study, maybe you did part of it, with augmentation of antipsychotics.
That's right.
So in other words, if you're under an antipsychotic and you give a 5-HT2A antagonist, if you've got every one of your receptors blocked, nothing's going to happen. But even at clinical doses in schizophrenia, the available drugs do not saturate 5-HT2A receptors. And of course, one exception, lumateperone. So if you add 5-HT2A to every other drug, it seems to make negative symptoms better. So there's some room, even with the normal clinical doses, to even get more 5-HT2A antagonism. So there may be ways in the future to play with that, to actually take your regular drug and make it saturating of 5-HT2A receptors by adding pimavanserin. The other would be just give something like lumateperone.
Yeah, and this may help explain why lumateperone did not have really much of an EPS or akathisia signal at all in the clinical. That plus, it does have lower affinity for D2. I mean, it's really more that the occupancy is in the range of clozapine, actually.
Right. The interesting thing is that when you're in a switch scenario, you're switching from drugs that have 80% mostly in that range, maybe about 60% to 80% D2 occupancy, with the exception of maybe two other drugs, and that would be clozapine or lumateperone, in which case you may have something like 40% D2 occupancy. Now, the reason that clozapine works is a secret.
Yeah, I was sitting on the edge of my chair just there, Steve. I thought you were going to unveil it to me.
Well, if nobody knows, they haven't told me either. But we think it's non-D2, so it's pretty clear that it's not that.
There's a lot of
lumateperone. It's funny. It's actually a presynaptic agonist, we think, as well as a postsynaptic antagonist. What that means is that it stops the release of dopamine so that you don't have to block it as hard because there ain't as much dopamine there in the first place. So therefore, you can get away with these lower doses of D2 occupancy. So in that case, in your treating psychosis or even mania off-label, what you're doing is you're going from a high D2 occupancy to a lower D2 occupancy, which helps your tolerability. And that's one of the other reasons to wash the first drug out, because if you're trying to go to the tolerability of something like a clozapine or a lumateperone, and you leave the first drug on too hard, you're going to have actually a net increase for a while in your D2 occupancy. So let the first drug go. Give it a day or two, depending on its half-life, and wash out one or two half-life. And then add, because what you're wanting is to have a situation where you have this moderate amount of D2 occupancy.
Yeah, it is mysterious how these drugs with lower affinity for D2 can still work. And the answer is obviously other receptors and other things that we don't fully understand yet. I'm going to switch to another very common clinical scenario, Stephen. You hear this all the time. So someone is following our advice. They're doing the cross titration, if you will. And the patient seems to be doing very well in the middle of this. And they stop. They get stuck in the cross taper. What can we tell people about that?
Well, it requires discipline to keep on stopping the first drug. And the reality is that otherwise you're going to be getting a lot of polypharmacy. And there's not necessarily any reason for doing it. The reality is that the more drugs, the more complicated life is, the more drug interactions, the more side effects. So it's best to try to hold the fort down with that patient with just one of the drugs. So if you basically go all the way down and you have cross titration, things are getting good, and people get scared. If it ain't broke, don't fix it, leave it alone type of thing. No, they'll continue down on the first drug you've been trying to stop and either allow the second drug to stay there or put it up a little bit. And that's generally a better way to do it for also cost considerations in some cases, but it's certainly mostly about tolerability.
Well, yeah, and the hassle factor of having to manage 2 prescriptions, if you will, as well. But I think you're right. Something we talked about earlier, sometimes what ends up happening is if you go too fast in this cross titration, it can look like the patient's not doing as well. So I guess that overlap time has to be managed pretty carefully because it may look like they're doing well, but that's only relative to pulling off the other drugs so fast that it looks like they need the first drug still. But it's not necessarily for efficacy. It's really for managing the rebound of the withdrawal.
You just said it, Andy, that the art of switching is managing the transition. And so you have to know why you're switching and you have to know what you're switching. Are you switching for efficacy or are you switching for side effects? That will change the way in which you manage the overlap.
Wait a minute. Let's expand on that a little bit. Tell me what you mean by switching for efficacy.
Drug's not working. I'm not getting an adequate response, either in mood or psychosis.
Exactly. Right.
And so I probably want to get out of Dodge pretty fast with the first drug. I said, I'm trashing this sucker. It ain't working. So in some ways, you want to get off of it as prudently, quickly as possible and get the other one started because the patient's impatient and wanting to be better, and we want them to. So in that case, you're going to push, maybe to the limits of what you think you can get away with in terms of stopping. Now, in terms of side effects, this is more like fine tuning. And so if you're switching for side effects, you don't want to ram things into reverse, as I was saying, and quickly change it. You want to kind of gently float the first drug down, and you can do that every month. You can take 3 months to do it. And I often do in patients that are, doing fine in terms of their underlying issue. You're not going to change, for example, you're switching for metabolic reasons. You're not going to, change much metabolically in a month to 3 months. The reality is this is a long-term side effect and a long-term reversal of that side effect. And so, there's no gun to your head to go quickly. When it's efficacy, there is. So that's what you have to decide, and you have to know, what's the sort of the easiest, softest ways to do it. Maybe as an outpatient, where you're seeing patients monthly, you make a change maybe 2 or 3 months in a row till you're finally at the destination, as opposed to something for efficacy where you may want to see a patient every 2 weeks or every week and, make an adjustment each time.
Steve, I want to parse something that you kind of just said. I want to parse the difference between tolerability and safety, because those are 2 different things. If we think of tolerability as something that the patient feels and is uncomfortable to them, and that can be sedation or nausea or akathisia, but then safety may be something the patient doesn't feel, such as their cholesterol going up, blood pressure going up, something like that. And it seems to me you're right that the way you switch differs depending on whether it's a tolerability or a safety issue.
Right. And the tolerability, people are not going to be very happy. They may fire you or just quit their meds if you don't rally to it. Doctor, this akathisia bothered me, do something, and I don't mean in 3 months.
Right. So as you said, for the safety issues, unless of course it's an acute safety issue like an anaphylactic response or something like that, or agranulocytosis, God forbid. But, for most of those issues, you can take your time, go a little more slowly.
Absolutely.
That certainly makes sense.
We get into trouble with weight and metabolics over time, and so we're not going to get out of that trouble very quickly.
Now, one of the things, I'm going to circle back to the industry-sponsored switch studies. One of the things is that's interesting about those studies is they don't really inform much in the way of efficacy from my point of view, but they do help a little bit in looking at sometimes safety or tolerability issues. And an example of that is their outpatient study was patients who were stable taking other antipsychotics, and they were essentially switched. Now, in that study, they gave the investigator discretion. They didn't prescribe how to do the switch. But the interesting point I want to make relative to what we were just saying is it's one of the few studies I've seen where patients not only didn't gain weight over time, they actually lost weight over the course of the year.
Yeah, I've heard the same thing and seen it anecdotally in patients. Usually, you're right. What happens is that the switch to a metabolically friendly, or you want to call that drug, like generally speaking, the ABC drugs and lorazepam and so forth, stops your weight gain. And so that's great. But, the question is, if you don't wake up and start that switch until you gain 40 pounds, it's not all that reassuring. You didn't gain another 40. So what you want to do is be sensitive to doing this early. But my goodness, if you can stop the weight gain and maybe reverse it, that would be great. Because otherwise, you're using various types of other medicines to get you there.
There is some data of switching to aripiprazole, lorazepam, and now lumateperone that maybe people can lose some of the weight they had gained with a previous drug. But I think you're right. If nothing else, it's very hard to lose weight, as you know. Once you've gained it, it's very hard.
Well, to your point, Andy, the studies that they did were they did even 6-week studies that people would gain, sometimes 10 pounds. If you switch to one of these other drugs that doesn't do that, you lose that 10 pounds. But if you gain 10 pounds and keep it for 6 months or so, now you're in trouble. So you can rapidly lose the recent weight gaining by just a metabolically neutral drug, but not chronic weight. Not so easy.
Sometimes I'm thinking of modern psychopharmacology, how we have these classes of drugs like SSRIs and the atypical antipsychotics. And something that you're always fond of saying is that the atypical antipsychotics, their differences are more similar, or their similarities are more different, as opposed to the SSRIs, which tend to be more uniform. But the atypicals really vary with their respect to their receptor binding profiles. And I feel like it'd be nice if we could really kind of match up the right drug to the right patient, but we're just not good at doing that.
Well, Andy, did you not go to the class in your residency where they taught you how to be a bespoke healer on Savile Row?
I slept through it.
Yeah, where you would actually measure somebody and fit them and make a specifically tailored suit for them. And seriously, that is actually what people need to do. And the art of psychopharmacology is knowing enough of the differences among these drugs to choose the very best one. If you just, know 2 or 3 of them, which is sometimes what happens with busy people, but it tends to be people maybe outside of our specialty that do a little of this work. They know 2 or 3 of them, and everybody's better at those 3 because that's the 3 sizes you got. If you don't, you sleep it too long, too bad. And so what you're saying is that by knowing, there's a dozen or 2 dozen drugs here, and there really is a place for each one of them.
Yeah, I really think so. I think, unfortunately, in the modern environment, there's always cost and access issues, and it's always harder to get to the newer drugs. And sometimes the newer drugs have certain advantages, maybe tolerability or safety, for instance.
Exactly.
So we really have to discipline ourselves, like you said, I'll give you an example, Steve. In my residency, our attendings would say, you must put each patient on a different drug. You must try all of these drugs. Now, granted, back in the Stone Age when I trained, there weren't as many drugs, but I don't think that's happening now in residencies. I don't think people are learning to use them.
Not only that, in the old days, we were able to use them off-label to say, well, it makes some pharmacological sense to try this new syndrome, maybe outside of the labeled claim. Well, lots of luck getting a new drug, even for a labeled claim, let alone off-label. So
That's right.
A lot of that innovation which occurred in practice is drying up. But there are clever ways to communicate with payers that get you there. But then people are learning that. But it does take extra time, which is a big aggravation. So not only are you treating patients, but you're spending time trying to get access.
Yeah, it really is a really unfortunate aspect of modern medicine. So what other advice can we give people as far as thinking about what are some of the pitfalls? What are some of the landmines here we need to be aware of?
I think kids basically doing things too fast is generally worse than doing it too slow.
I like that.
And so, if in doubt, slow things down. If in doubt, I got even another one. If in doubt, think. And we're so busy, we tend to want to do this. We're like, sorting mail into cubby holes and as fast as we can. And so sometimes you find one, well, this doesn't have a cubby hole for it. It won't fit or it's too big for it. Well, then stop, take a deep breath and think. And in some ways, it's a pain in the butt to do that because it takes more time and you're trying to stay on schedule and so forth. Everybody's busy. But on the other hand, it's fun. My goodness, you want to actually spend all day never thinking and just kind of sorting and doing things at the basal ganglia or your spinal cord level because it's just easy. And, that's no fun.
Turning the crank.
So, if you can't spend too much time thinking, you never get your job done. So you sometimes have to think in titration. This is a serious time for a patient who is not just coming back for a refill and doing fine and, talk about Johnny's dog or his mother, but if they're switching, you got to talk about the details of, what's wrong and why you're switching. Have in mind, is it fast or slow? Is it urgent or not? What am I going to go from and what I'm going to go to? And so, but that's fun. Why did you go into psychiatry anywhere? Into mental health treatment? And the answer is because it's a perplexing and challenging area. And when you figure it out and nail it, boy, you feel good.
Yeah, that's really true. We all have that experience when we finally kind of get somebody doing better. It really is. It feels like you've got the round peg in the round hole. The other thing I'm thinking about is I think a lot of times, like you're saying, busy clinicians, they kind of know the basics of the mechanism of action of a drug, but I think they forget about all these other receptors we've been talking about. And one of the things that's really been happening over the past few years is we're learning about more and more different receptors and what they may do. But I think the basics, just keeping in mind the various serotonin receptors, the various, you mentioned the 5 muscarinic cholinergic receptors, the histamine receptors, and the norepinephrine receptors, the alpha especially receptors, alpha 1 and alpha 2. That provides for a lot of variety with these drugs.
Absolutely. I mean, the monoamine neurotransmitters, then you got acetylcholine and histamine. There's only 5 neurotransmitters there, but some more receptors than that. But, it's going to get more mind-blowing as time goes on. We don't have time to talk about it, but just to tease, there's trace amine receptors now that are going to be important. There are cholinergic agonists. We've spent a lifetime blocking these receptors. Now there's a bunch of stimulations of the cholinergic receptors out there.
Yeah.
And, some very novel ways of looking at things that will, be something that will both enrich our field, but also, cause us to do that terrible thing I was talking about, stopping and thinking.
We have
but
to
meanwhile,
learn.
We can master this stuff pretty well. This is routine clinical practice. A new drug comes in every once in a while, and we have to readjust things a little bit. But basically, most people on here have been switching drugs for years, and they know most of these principles here. And the real only questions are when the new kid on the block comes in, which place do you slot them in, or do you have a new place for them?
Yeah, I find that interesting. It's almost like people shut their brain off when a new drug comes out because it's new. The other drugs, okay, I've got experience, I'm familiar, I know how to switch from one to the other, but for some reason, they get scared of the new drug. And I think if they apply some of these principles we're talking about and think through it the way we're talking about here, it shouldn't be so scary.
Well, you artfully guide all these people through that trepidation with your great narration here and pulling stuff out of your experts, including me today. So, I mean, I'm teasing, but in many ways, if you show people how to think about them when they actually, have something to know, they don't panic, they think.
So teach them how to fish, don't just give them a fish. That's what you're saying.
There you go.
All right, I find that fascinating. Well, the other thing that we didn't talk about too is all the other medications that people end up on. The fact is, it's very rare to find somebody who's just on an antipsychotic, and that's it. They end up on all kinds of other drugs, antidepressants, anticonvulsants, mood stabilizers. And then a lot of them end up on anticholinergics, sadly, benztropine, for instance. So, of course, that needs to be taken into account as well, doesn't it?
Heck yes. One of the things that we do badly, I think, in psychiatry, in the mood disorders, and particularly in the psychosis sphere, is over anticholinergize people, if that's a word. A lot of drugs you don't even think of as having anticholinergic properties, in fact, are. And so you add that too much together, you get all sorts of problems.
Yeah. Yeah, I'm also thinking about now getting into the world of pharmacokinetics, the drug interactions. You need to understand how is a drug metabolized, especially if you're bringing in a new drug that's metabolized, for instance, by 2D6, CYP2D6, and they happen to be taking an antidepressant that's a CYP2D6 inhibitor. Well, that's another reason somebody's not going to do well during a switch.
Right. And fortunately for most of the drugs we've been talking about today, the pharmacokinetic interactions are not paramount because one drug in the area that we've been talking about doesn't tend to change the metabolism of another one.
Right.
But patients I've seen data that suggests that most patients are on 5 drugs or more, unless you're over 65, in which case you're on 10 to 15 drugs.
Yes.
And so, those are the drugs that are going to change the metabolism of the psychotropic drugs that we've been talking about.
Well, Steve, I'm going to blow people's mind even more because what we haven't talked about is all of the over-the-counters and herbals and nutraceuticals that people take. And to go even another step further, we've known about tobacco smoking induces CYP1A2, and that's an issue for at least a couple of the atypicals, clozapine and olanzapine in particular. But how about this, Steve? Did you know that marijuana inhibits CYP3A4? And many of these drugs are metabolized by CYP3A4.
Good thing none of our patients are on marijuana, Andy.
It's absolutely true, Steve. I don't think any of mine use marijuana. But
well, it's probably not a real good idea for your psychosis clinic to have a lot of marijuana in it, but
but they do it.
So bad.
Yeah, they do it.
There's something bad about marijuana and psychosis that we don't understand. But you're right. If you take, and most people who are on it don't want to tell you, and they're taking it chronically. So
that's right.
The 3A4 is going to be inhibited. And the vast majority of drugs are 3A4 substrates. And that's so if you have marijuana, you're going to increase, at least subtly, if not moderately, the levels of all those 3A4 substrates.
I'm thinking in particular, Steve, of the ABC drugs, because those in particular can be associated with agitation and akathisia. And so I've certainly seen that. People will tell me, well, I switched to this, let's say cariprazine, and the patient was agitated. And I asked them, well, is your patient using marijuana? Of course they are. Well, you probably needed to slow it down a little bit.
Right. Well, you're probably not going to slow it down. You're probably going to reduce the dose of cariprazine.
Right.
I don't know.
So start with the lower dose.
Willing to stop their marijuana if they're taking it.
No. I mean, we can try to practice harm reduction and at least get them to back off the marijuana, but you're not going to get them to stop it.
So telling to stop it is basically in people who have, ultra high risk for psychosis, if we could identify them, or at least people who've had one psychotic episode. I'm thinking of a friend of mine who I just saw last week's daughter, who's in her 20s, and she had 3 episodes of psychosis from marijuana. Probably has a bipolar illness underneath it. Who knows? It's hard to tell, but she will not stop for marijuana. And so, it doesn't get it. And that is a different thing. It's probably pharmacodynamic in the sense it's doing something to receptors to trigger psychosis, as opposed to what you were talking about, which is to raise the levels. And so that can change the way you switch things. If you're switching to something that is, if you have a patient on marijuana and you're going to start a drug that is importantly metabolized by 3A4, you might want to make sure the dose is just a smidge lower.
And just to wrap that up, it's an issue with not only THC, but also CBD. So it's really, even if somebody's just using CBD oil, you still have to be aware. So the point is that there's all these over-the-counter things and other things that people are using that can potentially have interactions. So we always need to take that into account as well. Sometimes what I do, Steve, I'll have a patient fill up a shopping bag with every pill bottle in their house. I want everything you're taking. And you'll be amazed what you see, what people bring in this big bag. You'll see all kinds of over-the-counter.
That's another one. So that's a story in itself.
That is true. Not to mention the drugs of abuse. And even psychedelics are getting used more and more now. And that's a whole other topic, of course, the use of psychedelics therapeutically.
Yeah.
Well, Steve, I can't believe it, but the time has really passed here. It's flown by. We're coming up on an hour. I want to give you a chance. Any final pithy words of guidance to help our clinicians that might be listening to think about the art here that we're talking about of switching?
Right. Well, the art of switching generally means some cross taper. It generally means more slowly stopping the first drug than cold turkey, although we mentioned the 3 exceptions of the ADC drugs with very long half-lives. They are cold turkey, but generally not. And then starting the next one, you generally want to cross taper it up from a subtherapeutic dose, unless it doesn't have one. And we mentioned, for example, in lumateperone's case, you will start at the full therapeutic dose. But it's a cross taper, and it's driven fast by efficacy and slower for side effects. That's the general principle.
You know what I just noticed, Steve? This is funny. We use the words cross taper and cross titration interchangeably. That's sort of funny, isn't it? They're kind of the opposite of each other.
Yeah, well, maybe that was inaccurate on my part, but
No,
precisely, cross taper would mean to stop while you're stopping the one while you're cross titrating the other one up. So tapers down, titrates up.
Mm-hmm. So it's a cross taper titration.
There you go. Oh, you hit it.
Great. All right. Well, Steve, as always, I really want to thank you. I know you're super busy, and I know our audience really appreciates it. So I hope you've all found this to be very useful, if nothing else, but hopefully a little bit entertaining and time well spent. And I want to encourage you, please listen to the other podcasts that NEI has sponsored, both CME and non-CME podcasts. And of course, don't forget to tune in to our regular feature, the Psychopharmacology podcast that Steve and I do. So thanks so much for your time. Steve, thank you.
Yeah, great job, Andy. Pleasure working with you.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.